Hi everyone, in this video we will discuss about previous year MCQ questions in community medicine. A research is being conducted to find the association between aniline digestion and bladder cancer in workers of an industry who have worked for more than 20 years. Two groups were formed, one directly involved with the dye handling and the other group consisted of office clerks not directly exposed to the dye. Years of occupation was noted from previous records. What type of study is being performed? The keywords are previous records and the two groups are one with dye handling and not directly exposed to the dye. So the exposed and unexposed are there. They are developing the disease. Such forward-looking studies are cohort studies. But here the data is collected from the previous records. So study designs have been clearly mentioned in the YouTube video shown below. It is classified into observational and experimental. The observational is further classified into descriptive and analytical. In descriptive studies, we have case reports, case series, cross-sectional studies, longitudinal studies, and ecological studies. In analytical studies, we have cross-sectional studies, case control studies, and cohort studies. In experimental, we have randomized control trial. All these studies have study unit as individuals except ecological study. In ecological study, the study unit is population. In cross-sectional study, there is only a single time period where both exposure and outcome occurs. In case control study, it starts with the deceased and non-deceased. So the study is backward looking from outcome to exposure. In cohort study, it always begins with the exposed to the outcome. In prospective cohort study, it is forward looking from exposure to outcome and the outcome is in the future. Whereas in retrospective cohort study, it is also starting from the exposure to outcome, but the outcome is in the present and exposure is in the past. Coming back to our question, we have the exposed and unexposed and the details of the exposure are obtained from the previous records. So the study design is retrospective cohort. Which of the following is the strongest study design? We have a evidence-based pyramid. The below part is animal studies or laboratory studies, followed by case series, case reports, then cross-sectional studies, then case control studies, then cohort studies, then randomized control trial, then systematic reviews, and then meta-analysis. So the evidence from the studies or the quality of information increases as we move towards the upper part. The observational studies have a lower strength of evidence when compared to experimental studies and which is lower when compared to systematic review and meta-analysis. So in this question, the answer is randomized control trial. A researcher wanted to prove the relation between COPD and smoking. He collected patients' records from government hospitals and records of cigarette sales from the Finance and Taxation Department. This is an example of which design. The key points are records from the government hospitals. So it is from the public, a group of population. And cigarette sales from the Finance and Taxation Department, that also from a population. So which is the study which has study unit as population? It is ecological study. In a case control study, 300 women aged 20 to 45 years suffering from breast cancer were compared with age-matched 300 women without breast cancer. It was observed that 120 women among cases and 60 women among controls were obese. The odds of developing breast cancer among obese women is. Here the cases are breast cancer and controls are those without breast cancer. and the exposure is obesity. We have to find the odds ratio. Odds ratio equal to odds of exposure in cases by odds of exposure in controls. This is equal to A by C by B by D equal to AD by BC from the 2 into 2 table. The number of cases and number of controls are 300 each. Obesity among cases are 120 and obesity among controls are 60. Odds is equal to probability by 1 minus probability. This is equal to probability of an event to occur by probability of an event not to occur. Odds of exposure in cases equal to number of cases with exposure by number of cases without exposure. This is equal to A by C. Odds of exposure in controls equal to number of controls with exposure by number of controls without exposure. This is equal to B by D from the 2 into 2 table. Odds ratio equal to odds of exposure in cases by odds of exposure in controls, which is equal to A by C by B by D equal to AD by BC. And this is the 2 into 2 table of the question. So here the odds ratio is the cross product ratio, that is 120 into 240 by 180 into 60, which is equal to 8 by 3. The result is interpreted as the obese women of age 20 to 45 years have 8 by 3 odds of developing breast cancer when compared to non-obese women of age 20 to 45 years. Now coming back to the question, the answer is 8 by 3. Cross product ratio is determined by which study? We have already seen that it is case control study. Cross product ratio is the other name for odds ratio. What is the relative risk of developing pulmonary embolism in users of oral contraceptive as per the information given below? There is a table given. The formula for relative risk is incidence of disease among exposed by incidence of disease among non-exposed. This is the 2 into 2 table given in the question. The exposed are oral contraceptive users and the disease are pulmonary embolism. 200 exposed are there. 120 out of 200 has the incidence of pulmonary embolism. 80 non-exposed and 10 out of 80 is the incidence of pulmonary embolism in non-exposed. Relative risk is the incidence of disease among exposed by incidence of disease among the non-exposed, which is equal to A by A plus B by C plus D from the 2 into 2 table. This is equal to 120 out of 200 by 10 by 80 and we get 4.8. The result is interpreted as the women using oral contraceptives have 4.8 times risk of developing pulmonary embolism when compared to women not using oral contraceptives. So coming back to the question, the relative risk is 4.8. In a cohort of 500 women attending antenatal clinic, 70% had USG. This cohort was followed up after delivery. Of the women who had USG, 70 delivered low birth weight babies, whereas of the women who did not undergo USG, 50 delivered low birth weight babies. The incidence of low birth weight babies among women who had USG is. The women who had USG is 70% of 500, that is equal to 350. Now let's draw the 2 into 2 table. We know that 70% delivered low birth weight among the USG. This is A. 50 delivered low birth weight among the non-USG, which is 50. And we have got the 350 from the 70% of 500 and we got the remaining values. So the incidence of disease among exposed is equal to 70 out of 350, which is 0.2, 20%. So the answer is 20%. A researcher wants to know whether there is an association of CRP values with risk of MI or cancer. They started to take CRP readings. 4 values of relative risk were plotted, 0.5, 1.5, 1.7 and 1.8 with respect to CRP. So we have the relative risk values. Let's see how they are interpreted. Relative risk equal to 1, both exposed and unexposed have equal risk of getting the disease. If relative risk is less than 1, the exposed group has less risk of getting the disease when compared to non-exposed. And if relative risk more than 1, the exposed group has more risk of getting the disease than the unexposed. So here we can see that 3 values are above 1. That means the exposed group has more risk of getting the disease. That is, the CRP increases disease or cancer risk. A cohort study is undertaken to study the association between green tea intake and diabetes mellitus. Relative risk was found to be 0.85. Which of the following is correct regarding the association between green tea and diabetes mellitus? So we have the relative risk value 0.85, which is less than 1. That means green tea consumption decreases the risk of diabetes mellitus. The exposed has lesser risk of getting the disease. Which one of the following epidemiologic methods can be used to identify risk factors and estimate the degree of risk? Identifying risk factors is in case control study, which starts with the deceased back to the exposed. Then estimating the degree of risk like relative risk and all is in cohort studies. The answer is case control and cohort studies. What is the specificity of sputum microscopy in detection of pulmonary TB as per the information given below? There is a 2 into 2 table. The formula is for specificity true negatives by total non-deceased into 100. Here the true negative is 180 and non-deceased is 200. The 2 into 2 table is as shown. Test positive and disease positive is true positive. Test positive, disease negative is false positive. Test negative, disease positive is false negative. And test negative and disease negative is true negative. And the values from the question is as shown. Sensitivity equal to true positive by total deceased into 100. This is equal to 270 by 300 into 100, 90%. Specificity equal to true negatives by total non-deceased into 100, which is 180 by 200. 180 by 200 into 100 is equal to 90%. Positive predictive value is equal to true positives by total test positive into 100. This is equal to 270 by 90 into 100 equal to 93.1%. And negative predictive value is equal to true negative by total test negative into 100. This is equal to 180 by 210 into 100 is equal to 85.7%. The screening of disease is clearly explained in my YouTube video given below. Coming back to the question, the answer is specificity equal to 90%. CA 125 is the marker for screening of ovarian cancer. To characterize this test, histopathological confirmation of ovarian cancer was done in a cohort of patients. 60 out of 100 who tested positive for this test had ovarian cancer, and 20 out of 100 women who tested negative had ovarian cancer. What is the negative predictive value of this test? For better understanding, let's draw the 2 into 2 table. 60 out of 100 tested positive has ovarian cancer. So, true positive is 60. And 20 out of 100 women who tested negative had ovarian cancer. That is the false negative, 20. Now, negative predictive value is equal to true negative by total test negative into 100. Now, we get the true negative value as 80. So, 80 out of 100 is the answer. Which of the following is not true for taking a decision on screening for disease? The question is not true. Disease prevalence should be high. If a disease has high prevalence in the community, the screening program will be useful. Disease is lethal. It is also a correct statement. Early detection of a lethal disease by screening program is useful. Proportion of false negatives is high. It is a false statement. That is, If false negative means the disease is present but the screening test is negative. So that means the screening test is not useful. Then sensitivity and specificity are high. Sensitivity and specificity of the screening is high, will pick up more number of person with disease. So the answer is proportion of false negative is high is a false statement. All of the following concepts regarding the screening test are false except sensitivity depends on prevalence. It is a false statement. Specificity depends on prevalence. It's also a false statement. Both sensitivity and specificity are inherent characteristic of the screening test, so it cannot depend on prevalence. Positive predictive value increases with increasing prevalence. It is a true statement. Positive predictive value is a inherent characteristic of the population. That's a right statement. Now, positive in cases of highly sensitivity test means true positive in low prevalence scenario. This is a negative statement. There is a mnemonic, spin and snout. Sensitive test negative rule out the disease and specific test positive rules in the disease, which means that if a highly sensitive test it is negative, then the disease is negative. But if it is positive, we have to confirm it with a diagnostic test. So the last statement is wrong. Prospective screening is done in case of. There is a prescriptive screening and prospective screening. Prescriptive screening, people are screened for their own benefit to identify their disease. This is for early case detection. Prospective screening, this is done for benefit of others, especially for the control of a disease. So here the answer is immigrant screening. All other options are done for the benefit of the patient. Predictive accuracy of a screening test depends on all except. We know that in screening tests there is disease prevalence, sensitivity and specificity. We have never heard of a term disease incidence related to screening test. So by eliminating all other options, disease incidence is the answer. Thank you. You can follow me on my Telegram channel and please subscribe my YouTube channel if you like the video. The slides of epidemiological study designs and screening of disease are present in my slide share.